Good afternoon, Peter Goertz. I'm a psychiatrist. Do people mistakenly receive psychiatric treatment when they don't need it? The truthful answer, in my opinion, is yes, sometimes. And that treatment can include even psychiatric hospitalization, sometimes when it's not necessary. So this is a serious issue, and I make mistakes every day. I think that's important to admit. We're human, all of us. And we want to be truthful and show humility, and that way hopefully patients can trust us. Patients are wonderful teachers, and some patients I recently saw have again brought up this issue to me and taught me about it. So 3 patients I saw very recently, actually. One gentleman, a gentleman in his 60s, had suicidal thinking, was admitted to a psychiatric hospital, put on multiple medications, and I saw him a little bit later when he developed medical problems and was transferred to a medical floor. And what turned out to be the case, as far as I could tell, was his caregiver left for an unclear reason. I'm not sure why. And he had a very difficult social situation. His living situation was difficult. And it was basically a place that was not livable anymore. So he had a lot of stress, no caregiver, no place that was functional where he could live, and he became overwhelmed and said he was suicidal. So pretty much to a large extent, that patient's situation was a social issue, which is often the case. The next patient was a patient who developed an acute neurologic issue, and the family brought her into the hospital. She was admitted to a medical floor, and she appeared delusional. She'd been seen and before I saw her and was felt to at least potentially be psychotic with religious delusions and very preoccupied with religion. And when I saw her, the acute neurologic problem had resolved, or pretty much resolved as far as I recall, but she was still very focused on religion, and she could talk for a long time about it. And I was wondering, is this lady psychotic or not? I mean, talking about religion in and of itself definitely is not psychotic, but she was quite preoccupied and really wanted to talk about it, which is fine, but sometimes people who are psychotic also do that. I did not see any clear evidence of psychosis, and I spoke with the family, and the family told me she's always like this. She likes to talk about religion, she's very religious, focused on religion, and she's never had any mental health issues in her life. So that was important to know, and often it's crucial to get collateral history from family members or anybody who knows the patient, and that can really clarify, as it did in this case, what's going on. The third patient was a gentleman with dementia, and he was felt to become agitated, and I spoke with his family, and apparently he had become agitated out of frustration because he didn't understand what was going on, and that definitely can happen. So it wasn't that he primarily had an agitation problem, but the agitation seemed to have been from dementia, not knowing why he was in the hospital, being unclear, and family members not being around him. And when I saw him, there were 2 family members with him, and he was fine. He was a gentleman, he was cooperative, said he would cooperate. So these 3 patients, the first one illustrates that it's key often to look at the social situation. That can be such a stressor for patients that they can even become suicidal, like this gentleman. And the treatment for that suicidality might actually be to improve the social situation rather than medication, and maybe he didn't need to be even psychiatrically hospitalized at that point. Even though if he was suicidal at the time, one could maybe justify that, and maybe it was appropriate. The second patient had the neurologic issue, the acute neurologic issue, and the religious preoccupation. So we want to really be careful not to label people as psychotic just because they have beliefs that are different from ours, just because they have ways of speaking that are different from ours. We want to really be careful and look at the level of functioning. And this particular lady with the religious focus had been functioning very well. She'd actually been taking care of a family member herself and working, as far as I recall. So this lady had no impairment in her level of functioning, except for acutely because of the neurologic issue, but that appeared to have maybe resolved by the time I saw her. The third patient just seemed to have been lost and not to have understood the situation in the hospital because his family wasn't around him. So that situation seemed like the gentleman needed support by the family and did not necessarily need medication for agitation. But of course, it's difficult to know if the family's not there and the patient doesn't really answer your questions clearly. So patients, if they're mistakenly diagnosed and mistakenly receive psychiatric treatment, they can be treated, of course, with medication, including even antipsychotic medication. Psychiatric medicines can have potentially serious side effects, for example, with the antipsychotics, extrapyramidal symptoms, so Parkinsonian symptoms, for example. So we want to try, again, humility is key. We want to really, as psychiatrists, as doctors, as humans, we want to be truthful and try and be humble. And with our patients as psychiatrists, we want to look at the biological aspect, the psychological aspect, the social aspect, and the spiritual aspect, and try and get a whole picture, a good picture of the patient. So that takes an open mind. It takes time. So you need to often take the time to speak with collateral sources, so family members who have more information, and that's just being thorough. So you want to get enough information to do a good evaluation, and again, the collateral information can be key. Thank you very much.